the whole afternoon, and just during the coffee break, I heard from a lot of people, this is a rather tough topic, and it has been recognized. Let's see, okay, we'll do it like this. Has been recognized by John West as well. I mean, we don't have to be ashamed. Respiratory mechanics is pretty tough. What I would like to do is discuss it as much as possible, how we can use it at the bedside. So what I'm going to do is give a little bit of a wrap up what has been discussed in the previous talks. So there is some overlap, but this is on purpose because I know it's a difficult topic. Then we go a little bit deeper into airway resistance, intrinsic PEEP, about the time constant, and if there's any time left, we'll discuss respiratory effort. And we're here with a small group, so if I'm going too fast, just tell me. Put the brake and ask me to stop and repeat it. I mean, we're going to discuss some very important topics here. So first, and you don't have to use your phone, just as a quick question. Who is using respiratory mechanics in his ICU? And that respiratory mechanics be defined as measurement of respiratory compliance and resistance. So, who does that in every patient at the bedside? Wow, not too bad. So, only in the ARDS patients. Only in COPD? Never? Are you raising your hand? Never? I'll get back to you. Don't worry. So let's start from the beginning again. I mean, as we're sitting here in this room, ventilation is driven by the respiratory muscles, right? This fantastic muscle, the diaphragm, if it contracts, it moves downward, it generates a negative pressure, negative pleural pressure, and air flows from the atmosphere into the lung. But when the patient is on the ventilator, in particular when the patient is on a partially supported mode, things get a little bit more complicated because now there are two pressures acting on the lung and there are a couple of opposing pressures. And this all is described, and I'm sure you've heard about it, in the equation of motion. It's a mathematical framework that describes all the pressures applied to the respiratory system. And it's based, you remember that from middle school, based on Newton's law. Action is minus reaction. So in a patient on a partially supported mode, the forces that are applied on the respiratory system are the pressure delivered by the ventilator and the pressure delivered by the respiratory muscles. And we can replace that by the pressure developed by the ventilator by airway pressure. So these are the two pressures applied to the respiratory system. What are the opposing forces? Because the lung doesn't want to extend. So the most important, there are a lot. If you go to the literature, there are actually a lot of opposing forces. But we keep it simple today, and that's difficult enough already, I guess. There's two important opposing forces. And the first one is the elastic recoil system. Again, the lung doesn't want to expand. So we have to overcome the elastic recoil pressure. And the other thing is, we have to overcome resistance. So there's a certain pressure needed to overcome resistance in the airways. So if I rewrite this, there's two pressures applied to the respiratory system, ventilator muscle, and there's two opposing pressures, elastic pressure and resistive pressure. Right? Equation of motion. Now, as Davide already explains to you, the elastic pressure depends on the elastance of the respiratory system and the volume above FRC. Right? And the resistive pressure depends on the resistance in the respiratory system and the flow. It's as simple as that. Now, let's take one step back. We have our patient on controlled ventilation, so we don't worry about the muscle now. So the pressures that are important is only the airway pressure applied to the respiratory system and these opposing forces, opposing pressures, as I already told you. These pressures will just get for free from the ventilator. Airway pressure, tidal volume, flow, you just get them from the ventilator. And the other ones, we have to calculate. And we'll do that. And it's a little bit of a summary of what we did earlier in the earlier talks. Again, so what's compliance?
Volume change by unit pressure change.
Exactly. Thank you very much. So the willingness to distend. Delta V divided by delta P. That's the compliance. And the inverse is the elastance. As simple as that. So my question here is, what is the compliance in this patient? So this is a patient on volume controlled mode, peak pressure 38, plateau pressure 17, and a tidal volume of 420. So what's the compliance here? Are we going to use the system or are we just going to raise hands? System.
The system is open.
The system is open, okay? Yeah, can I go to the next slide?
Yeah.
Oh. Go to the next slide, or?
Yes, I think I see that your question is a bit.
I think it's not the same.
Oh, no, this question is not on the system.
Oh.
You can give me.
I'm very sorry. So we're going to raise hands. Real quick. Who says A? Nobody. B? Quite a lot. C? And who doesn't know? Okay, thank you. That's the right answer. Because we have to do, to calculate a compliance, we have to do an end expiratory occlusion as well. So in this example, this is the compliance. It's 420 delta V divided by delta P, and delta P is 17 plateau pressure minus the total level of PEEP, right? You're never going to forget it, I hope. So now, is this question there, or? Okay, so we can do this real quick. We have calculated the respiratory compliance now. And how can we assess, and it has been explained 2 times, so you can't be wrong here. How can we calculate the compliance of the lung? So, just using Newton's third law. So we do a relaxation, intermittent occlusion during inspiration, or we need this balloon, or can you use either 3 of the techniques?
Please vote.
Please vote. Should I go to the next slide?
Yes.
Okay. Yeah. Are these the votes from Romania, or? Okay. Well, I'm afraid the answer is we need the esophageal balloon, right? And now I'm going to do an experiment here. I'm not sure it's going to work out, but I want you to understand this. What David already told you, what I brought from home is 2 things. The lungs of a patient and a chest wall. I'm going to apply, say, a plateau pressure and inspiratory plateau pressure of 25 centimeters of water. It looks like this. This is the lung. This is what happens. 25 centimeters of water and inspiratory pressure. But this is not your patient, right? Your patient, I'm not sure it's going to work out. I hope you're not confused in the end. But the patient has a chest wall. So the lung, and the lung is in the chest wall. I'm going to apply 25 centimeters of end inspiratory pressure again. Oh, this is only the volume. So the same airway pressure on your ventilator, but the stress on the lung is less, right? Because, as Davida already told you, we also need a little bit of pressure to expand the chest wall. Now, I brought another patient. So this is a patient with, say, overweight, or a lot of ascites, or at least a very stiff chest wall. So same lungs in this very stiff chest wall. Again, 25 centimeters of water of plateau pressure. Might be even a little bit more. But now you can see, despite the fact that the plateau pressure is the same, the stress on the lung is completely different. Because in this case, I need a lot of pressure to expand the chest wall. And the lung is really happy because there's no stress on the lung, right? So there's two things to be learned, and it's just a repetition of what was told earlier. The airway plateau pressure doesn't tell you a lot about the stress on the lung, because it depends on the chest wall as well. And the other thing is, the only way we can actually calculate the transpulmonary pressure is the esophageal balloon. So please keep this in mind. So you've seen this picture, and we can make it very, very complicated because the chest wall has a different compliance compared to the lung. But for now, I mean, it has been explained. I don't want to worry about it. Remember this when you're back in your ICU on Monday. Okay, give me some causes. Why is the compliance of the chest wall reduced? Give me a couple of clinical reasons. Obesity, very good. Another one?
Sorry, what was that?
He said obesity, overweight. Burns, exactly.
Neuromuscular disorders.
Exactly.
Systemic sclerosis.
Exactly. Well, okay. There's quite a lot actually. And so give me a couple of reasons why the compliance of the lung is reduced. Fluids, it's more chest wall. Or if you mean interstitial fluid. Interstitial fluid. Okay, right? Fibrosis, ARDS, edema, all kind of interstitial lung diseases, hyperinflation. So there are different causes for reduced compliance of the lung and the chest wall. Very important to remember as well. So now, I think, because things are pretty complicated, but we want you to go home with certain messages. And again, it's a little bit of a repetition, but a plateau pressure of 30, is it always bad? No, I think Davida explained to you. It's not always bad, but if your fellow or your resident tells you plateau pressure is 35, at least you want to go see the patient, if this is fine or not. It's not per definition a problem, but I think it's a patient you have to evaluate. Is this acceptable? Is this indeed a patient with a very stiff chest wall? And otherwise, it's probably unacceptable. So that could be one of the take-home messages. A plateau pressure of 30 is not always bad, but at least it should warn you. And if you want to really keep it simple, well then I think what the guidelines for lung protective ventilation say, try to keep your plateau pressure below 28. But remember this, I mean, if your plateau pressure is 28, you're not happy at all. So that's something you should remember. I think I more or less can skip this. I think Claude very well explained the driving pressure, so I'm going to skip this. Or is everybody fine now with the concept of driving pressure, or you want me to explain it again?
Can you go back again?
Back?
The driving pressure. Driving pressure.
Driving pressure. You want me to explain? Very brief summary. Everybody knows this paper by Marcelo Amato, right? I mean, that's how driving pressure became popular again. And then, again, to make it simple, lung protective ventilation more or less dictates us tidal volume of 6 ml per kilogram body weight. Tidal volume corrected for body weight. But look at these two patients. Both patients fulfill criteria for ARDS. If these patients would be 70 kilograms predicted body weight, both would be fine with 420 ml of tidal volume. But you can imagine in this patient, the 420 ml is distributed in this part of the lung. While in this patient, the 420 ml is probably distributed in this part of the lung only. So our criteria tells us 6 ml per kilogram predicted body weight is fine, but if you see these CAT scans, it's probably not fine for this patient. So that's why the idea comes from, we're not going to correct for predicted body weight, but we want to correct for the severity of ARDS. And that's what Amato basically did. So try to correct tidal volume for severity of ARDS. So that is, and Claude already demonstrated this to you, it's tidal volume divided by compliance of the respiratory system. You're never going to forget this anymore, right? Compliance. And the unit, of course, of tidal volume is ml, and of compliance is ml per centimeters of water. So the final unit is centimeters of water, and that's just driving pressure. It's as simple as that. It's tidal volume corrected for compliance, which gives you a pressure. And then that nice New England paper demonstrated, but we have to be careful, it's a reanalysis of data, but that paper demonstrated that driving pressure much better predicted mortality than tidal volume. And you've seen this slide. He actually demonstrated that a driving pressure higher than 15 centimeters of water was associated with higher mortality. But you now immediately understand the problem of this study. Again, here it is. It was resistance of the respiratory system. It was not corrected for severity of the lung disease, right? It would be much better if we could correct tidal volume for compliance of the lung. But it's better than we did before, I guess. Okay, is this enough about compliance? Let's move forward. And I think we haven't really touched upon this too much, so this is a very interesting topic again. Airway resistance. I think Diederik already showed you that the resistance in the airway is the highest, not in the bronchioli, but it's somewhere around 4th, 5th, 7th generation. That's actually shown here. And what's shown here, physiological concept as well, of course, the resistance of the lung depends on lung volume. The higher the lung volume, the more the lung is open, the higher the diameters of the airways, the lower the resistance. Right? We're going to skip this one because Claude exactly asked the same question. So we both think this is an important question. So who thinks it's number 1? Just raise your hands. Three, 2.5, 3.5, 4. Okay, it's number 1. Very good. So, where does the concept of airway pressure come from? And I'm sorry, it's pretty tough physiology, but I think it helps in your understanding what is going on. I've already shown you this, right? Plateau pressure. So no flow, plateau pressure depends, elastic recoil pressure, and the total amount of PEEP. The peak pressure, as has been demonstrated, depends elastic recoil pressure, the pressure needed to generate flow, and the total level of PEEP. So if we subtract 1 from 2, then peak minus plateau, we can get rid of, now it's working. So we get rid of this, we get rid of the PEEP, so we only have the respiratory resistance times flow, and therefore if we reorganize this formula, the resistance of the respiratory system can be calculated as peak pressure minus plateau pressure divided by flow. Then of course it's very important that you can only calculate this in a patient that is in a constant flow mode. So only in a patient on volume control, because the flow has to be the same throughout the whole inspiration. Okay, so just as a quick example again, patient in volume control ventilation, tidal volume of 420, then P peak is 38, plateau pressure is 17, divided by the inspiratory flow you get from the ventilator. So in this patient, resistance is 34 centimeter of water per liter per second. Right? Well, you could ask, why you want to know this in the first place? Well, there's two things. And the first, I have to admit, is a little bit academic. What you can do, there was a fantastic paper by Martin Tobin a couple of years ago. You can measure respiratory resistance in a patient with asthma. You give albuterol, and a few minutes later, you measure the resistance again and see if there's a decrease in resistance. If so, you provide more albuterol, repeat resistance, so you know how much albuterol you have to give until there's no more decrease in respiratory resistance. It's nice to do, but it's pretty academic. The other thing is looking at the risks for hyperinflation, and I think this is going to be an important part of the presentation. In patients, and you've seen this before, with COPD, with asthma, hyperinflation may develop, which means that end expiratory lung volume increases and increases. And this is, of course, a little bit exaggerated, but this is what happens. After each breath, a little bit of the tidal volume remains within the lung. And that is, of course, it's no surprise, associated with border trauma, hemodynamic instability, high work of breathing, and asynchronies. So how are we going to quantify hyperinflation? Just yell. How are we going to quantify the amount of hyperinflation?
Measuring autopy.
Autopy. What? Is that something else?
Total.
Sorry?
The total PEEP will give us a...
I'm sorry. It's
Total PEEP.
total PEEP. Yeah, total PEEP. Anything else that is more or less? There's another way. Very classical one. Actually measuring the volume. So there's three things we're going to go through rapidly. It's going to be discussed in much more detail tomorrow, but just so you can start thinking about it a little bit. So this is no surprise. You've seen already this. So in some of the patients you see that expiratory flow has not stopped when the next inspiration comes. That gives you at least an idea that there is a risk for hyperinflation. And I think that's what everybody will do. I think you already said that. You look at it all the time, and we all should do that.
You just have a comment?
Sure, sure.
You comment about the difference between, we are at same flow and volume. How do you explain this difference? You see, at the end of the inspiration.
Yes.
So probably...
Yeah,
probably
right.
You see,
No, go ahead. It's either...
If it's true, if you retain this difference.
I don't think there's any... Sorry? there's any effort by the patient here. So it could be that there is effort. I mean, you always have to be careful if there's changes in pressure right here in the volume controlled mode. But I don't see anything really in the flow signal here. I'm not sure. What do you think? Do you think it's an effort by the patient?
It's a possibility, but we can conclude we have no esophageal pressure. We can.
No.
The second explanation is a change in compliance.
Right. Yeah.
So,
Right.
if it is a severe COPD patient, we might have some
Differences in compliance here. Yeah.
problem.
Okay. Who can give me, and this is simple, and I'm sorry for the people who are very familiar with this, but I mean, there's a little bit of a mix in the audience. Who can give me a very clear definition of intrinsic PEEP?
So we have to do expiratory pulse for 4 seconds and then...
No, sorry. A clear definition. What's intrinsic PEEP? I mean, a patient with COPD walking here outside can have intrinsic PEEP. What's intrinsic PEEP?
It's pressure and expiratory.
Inadequate expression.
Inadequate expiration? No. In the end, the unit has to be centimeters of water because it's a pressure.
So it's end expiratory pressure.
Yeah, it's the pressure within the alveolus at the end of expiration. But this is very important. If you go into the pathophysiology, the definition is very important. As we are sitting in this room, hopefully, at the end of our expiration, the pressure in the alveolus is atmospheric, 0. In a patient with asthma or COPD with increased airway resistance, there's a limitation of expiratory flow. At the end of expiration, the pressure in the alveolus can be, for example, 10 centimeters of water. So the intrinsic PEEP is 10 over here. And something else might happen. And that's called flow limitation, when there is a collapse of the airways, which may also result in development of intrinsic PEEP. So a positive pressure in the alveolus at the end of expiration. Keep that in mind. So this is what we have already seen. This is pretty easy. How we're going to measure intrinsic PEEP and expiratory occlusion. There's a rise in pressure here. And in this case, extrinsic PEEP is 0, intrinsic PEEP 10 centimeters of water. How do we do this in a patient on a partially supported mode? So your patient in pressure support, how are we going to measure intrinsic PEEP?
I said that he has an intrinsic PEEP which is higher, that would go, measurement of the ventilator would go higher.
But this patient might have a respiratory rate, say, of 20.
We ask the patient to hold breath for a while.
Yeah.
So yeah, to hold the breath, so do an end expiratory occlusion, but you know what's going to happen? Patient not happy, right? And I think it's very hard to get a period of 0 flow, because that's what we're aiming for, right? No flow between the ventilator and the alveolus. And that's only what we can do in a patient in a controlled mode, preferably when this patient is on full neuromuscular blockade. Anybody in the back? How are we going to measure intrinsic PEEP? Okay. Do I hear esophageal balloon? That's right. Okay. Again, go back to the physiology. This is important again, because then you understand why you can only do this with the esophageal balloon. So this is, don't worry about mechanical ventilation. What I try to draw here is an alveolus, and this is the atmosphere. So this patient has intrinsic PEEP of 10. Now the diaphragm contracts, because the patient wants to take the next inspiration. What the patient has to do to get air into the alveolus is try to get the pressure within the alveolus lower than atmospheric pressure, right? Because air is never going to flow in when it's 0 here and 5 centimeters of water here. So what the patient has to do is try to reduce the pressure in the alveolus from 10 to 9 to 0, and then a little bit less, say to -1. Only then air will flow from the atmosphere into the alveolus. And that's what I've shown here. So this patient, intrinsic PEEP of 10, he tries to breathe in, so he has to drop the pressure in the alveolus first from 10 to 0, and then it has to get negative to get air from here into here. And now if you understand this, you understand how to measure intrinsic PEEP. Indeed, by inserting the esophageal balloon and measure, so that's right here. So this is the flow, this is a patient, say, on pressure support. This is the flow, and this is esophageal pressure. And the drop in esophageal pressure from here until the moment inspiratory flow starts is defined as intrinsic PEEP. Right? Everybody get this, or? Okay, good, simple. No, it's even very much more complex, but I guess you're going to discuss that tomorrow, I'm pretty confident, because when people using their expiratory muscle, it's getting more complicated. So you have to be careful in your ICU, but we discuss it in detail tomorrow, or otherwise in the discussion. Then, go back to this patient, they'll say controlled mechanical ventilation, and you have measured the intrinsic PEEP. So you do this end inspiratory and expiratory occlusion, you'll find 10 of PEEP, and we're very happy. Intrinsic PEEP is 10. Well, maybe not, because in the lung of a patient with asthma, there's not just one intrinsic PEEP. There's a lot of intrinsic PEEP, perhaps 1 million intrinsic PEEP, because every alveolus has its own intrinsic PEEP. So for instance, in this alveolus, intrinsic PEEP is 10. In this one, where the airway is totally occluded, it may be 6. Right here, very severe obstruction, it may be 20. And in this one, it may be 14. So there is not one intrinsic PEEP. What we measure is a kind of average intrinsic PEEP. So that's why, and that's, I'm sorry, this is nothing new. This is really ancient work, actually, from the 80s. That's why Tuxen at that time suggested that it's better to measure a volume instead of a pressure. And that volume is the volume and inspiration. And the volume and inspiration is defined as the volume above FRC after an inspiration. And the volume of FRC and inspiration, VEI, is the tidal volume plus this volume and expiration. How are we going to measure this? Well, it's actually 2 ways. I mean, it's already said here. You disconnect the patient from the ventilator. You let him exhale for 30, 60 seconds, 2 minutes, and collect all the air in a big bag. Or you have this very sensitive flow meter. I mean, that's, I think, more or less, again, we're going to discuss, because Claude did very nice studies on this, but just as an introduction, this is a very nice way of measuring pulmonary hyperinflation. And Tuxen has demonstrated that if your volume and inspiration is lower than 20 ml per kilogram body weight, there's a very low risk of barotrauma. There's a very low risk of hemodynamic instability. And if you go back, I'm going to be honest right away, if you go back to the original studies, got them with me, this is based on a rather small number of patients. But I can tell you from my own clinic that since we use this technique, that in every patient with asthma or COPD, and we apply a volume and inspiration below 20 ml per kilogram, whatever happens with CO2, we've never seen a pneumothorax or hemodynamic instability anymore. But, and you're going to show it tomorrow, I guess, we need more data to confirm this. But if you want a kind of take-home message for this, I think this is reasonable. The problem is, let's be honest, you probably think, well, this is very nice, but I'm not going to carry a big bag in my ICU, collect the air and try to measure the volume somewhere. It's pretty hard to get these very, very sensitive flow meters. So what is suggested, that you can use this formula, which actually predicts the volume at end inspiration. Has not been very well validated. And you again have the problems, as I discussed before, with all the pressures. But it's a reasonable estimation. And at this moment, we are doing a study to compare this to the gold standard, where we let patients exhale forever. But for now on, I think, and I'd love to hear your opinion tomorrow, I think it's a reasonable way of doing it. Okay. Now we understand the physiology a little bit more. We have a patient with COPD on controlled mechanical ventilation. Is this controlled? Yes, controlled mechanical ventilation, and we want to set the extrinsic PEEP. Just be honest, how would you do it in your clinic? You can use your phone now, I guess. Is that right, Estelle?
Yes.
Okay. Oh, 8 minuten. Oh yeah. I'll speed up a little bit. Okay. So most of you are going to match intrinsic PEEP. Okay. Let's see. Again, go back to the physiology to understand what's going on in these patients. And this is these are, I didn't even reference it. These are fantastic pictures from the textbook by Martin Tobin, Principles and Practices of Mechanical Ventilation. I think everybody should have the book in his office.
Sorry, can you please repeat it? It's one of my question literature. So
it's the textbook by Martin Tobin, Mechanical Ventilation, Principles and Practices in Mechanical Ventilation. I think it was a new release in 2016.
But it's changed slightly.
Okay, again, what's going to happen if you are on the ventilator and ventilated with PEEP? So this is how we're sitting in the room, right? We all agreed, because I didn't hear anybody say anything, so we all agreed, while we're sitting here, intrinsic PEEP is 0, right? Now, if we are intubated, we are on the ventilator, and I set the PEEP at 10, of course, my intrinsic PEEP will be 10. Can't be anything else, right? So this is our patient with asthma or COPD. At the end of expiration, the pressure in the alveolus very likely will be higher because there is an opposing force. I mean, now there is not a ZEEP, but there is 10 of PEEP. Right? So it's harder for the air to get out of the alveolus. So the only thing you would think can happen is an increase in intrinsic PEEP. Right or not? And this is what happens, because here's a little bit of the confusion probably, in patients with airflow limitation, collapse. And there will be, because Claude did fantastic studies on that, he will discuss it in more detail, but I want you to get for now the simple concept here. In a patient with flow limitation, perhaps extrinsic PEEP can open up the airways a little bit and at least prevent further development of intrinsic PEEP. Keep this in mind. Oh, and that's the other thing, at least what I learned in medical school, is that it is a kind of waterfall hypothesis. It doesn't matter if you apply PEEP, because it's like a waterfall. This is not a waterfall. This is, in the end, one compartment. So if you increase pressure here, it's harder for air to flow from this compartment into that one. So I think the waterfall hypothesis is not true. So now, and I think this is a fantastic study. It's a small study, but it helps you think how you would set your level of PEEP in patients, asthma, COPD, on controlled mechanical ventilation. So what they did, small study, I'm sorry, but that's it. They applied PEEP, external PEEP, at incremental steps, and it's shown here as percentage of intrinsic PEEP. And for the whole group, what you'll see, the higher the extrinsic PEEP, the higher the total level of PEEP. Basically, what I've shown you right here, right? So this appears to happen for the whole group. The higher extrinsic PEEP, the higher the intrinsic PEEP. But you always have to look at the individual data, and that's what we're going to do right here. So right here are the data for every patient. Extrinsic PEEP, and now here hyperinflation volume or FRC. Let's start out with this patient in green here. So increasing extrinsic PEEP increases FRC, so increases the degree of hyperinflation. Exactly as was written in the Tobin book. But this is interesting. In this patient, the purple triangles, adding extrinsic PEEP actually decreases FRC. So there's different responses in different patients. And right here, 3 patients, just for our understanding what's going on. Patient A, patient B, patient C. The upper curve is the plateau pressure, intrinsic PEEP, and the FRC. So this is a typical patient. If you apply extrinsic PEEP, the hyperinflation, say, let's take this one, the total level of PEEP, actually decreases until extrinsic PEEP is higher than intrinsic PEEP. So in this patient, you may want to apply extrinsic PEEP, right? In this patient, it doesn't really matter. If you apply extrinsic PEEP to the level of 100% of intrinsic PEEP, nothing basically happens. FRC, total PEEP, plateau pressure. And in this patient, the moment you start applying extrinsic PEEP, the total PEEP increases. And now the problem here is that you can't predict if your patient is in this group, or this group. So what you basically have to do in every patient, you take a chair, you sit next to the ventilator, you apply PEEP, and you do an inspiratory or expiratory occlusions with every level of PEEP up to 100% of the intrinsic PEEP. Above that, you almost always see an increase in hyperinflation. So this is physiology at the bedside.
Which one of them had expiratory limitation? You know that?
No, they don't know. I mean, and that's the problem. I mean, it's not like this patient had a more severe reduced FEV1 or had more this or that. But again, this is a small study. This is 8 patients, and I don't want to discuss your studies because you're going to do that tomorrow. But I think this is, despite the fact it's such a small study, it tells you that you have to understand these physiological principles to prevent the complications of barotrauma, pneumothoraces, and so on and so on. It's a very important concept. I really can recommend you to read the paper.
I testify that it works at the bedside. You can do it at the bedside with modern ventilation.
Right, yeah. Okay. I got a few more minutes, I guess. This is not, because remember, what we have discussed up to now is in a patient on controlled ventilation. Now we're going to patients on, say, pressure support ventilation. So what's your strategy over there? Did I have a question or can't remember? No, I'm just going to tell you. Okay. Again, 10 of PEEP, ZEEP, 0 of extrinsic PEEP. For this patient on pressure support, to trigger the ventilator, what he has to do is reduce the pressure in the alveolus by, say, 11 centimeters of water, right? Otherwise, never air will flow from the ventilator into the lung, so the patient is unable to trigger. So this is what the patient has to do. With every breath, he has to generate a pressure of 11 centimeters of water. Right? So now, if I add, say, 8 of extrinsic PEEP, it makes it much easier for the patient to trigger the ventilator. Because now, in this case, he only has to reduce the pressure here from 10 to 8, and one more to trigger, so by only 3 centimeters of water. So that's the reason why we want to apply extrinsic PEEP in assisted ventilation. And of course, we have to be careful that it doesn't increase hyperinflation. But if you don't add PEEP, it's probably very difficult for the patient to trigger the ventilator. Okay, and the quantification I'll leave up to Claude. He's an expert on it, so I'll leave it up to him. But this is the physiological concept. So, well, I think I've discussed all of this. Mr. Chairman, I think I'm through my time, right?
No, great. So I have 2 more minutes.
2 more minutes. Okay, now then I'm going to conclude. Okay, we can do this next year or so.
No. It's very important to the concept that Claude is going to discuss tomorrow. So you have 10 more minutes.
10 more minutes? Okay. At the time the first one of you falls asleep or pretends to do so, I'll stop. Okay, we'll go back.
You have 30 more minutes of questions.
Okay. So there's 2 more concepts now I would like to discuss. And 4 is the time constant, and we leave the question. Just stay with me. Time constant is an important concept here. Because the time constant determines the rate of change in volume. The rate of change in volume of the lung, of the respiratory system, of a balloon. I mean, it's just a physical law. The time constant has nothing specifically to do with the respiratory system or anything. It's just a physical law. And the time constant can be calculated by multiplying compliance by resistance. And now, again, it's a law of physics. After one time constant, an object, say a balloon, is empty for 63% of its volume. After 3 time constants, and I'll get to the practical application, stay with me. So after 3.7 time constants, the balloon is empty for 95%. Okay, a practical example here. Say the patient has a compliance of the respiratory system of 60 milliliters per centimeter of water, and the airway pressure is 33.6. Then the time constant is 2 seconds. So after 2 seconds, it's empty for 63%, right? After 3.7 time constants, it's empty for 95%. So basically, there's no risk of hyperinflation. So 3.7 times the time constant we just calculated is 7.5 seconds. So that's the time we need for exhalation, right? 7.5 seconds. So what is an optimal respiratory rate for this patient? And again, it's just a very simple physiological approach. It's 60 seconds divided by 7.5. So the optimal respiratory rate for this patient would be 8. And I know, I mean, if you have this patient with asthma of COPD, this is really fun. I mean, just calculate these kind of things at the bedside. Tell them, your fellows or residents, how to do it. And I'm not sure I'm going to say I guarantee you, but I think it's unlikely that you will get a barotrauma or any problems with hyperinflation. If you use the simple physiological principles, time constant, volume and inspiration. Does anybody ever calculate the volume and inspiration or the time constant? Okay. So one person. Try to take this home so you can justify for yourself why you came all the way to Brussels. Take this home with you. I mean, it is important. Again, we see quite well, you can confirm, you were a fellow at our unit, when I was in Nijmegen at least, we saw quite some patients with COPD, and once we started using these kind of principles, we didn't see any pneumothoraces anymore. It's simple. There was a question in the back. Yes, please.
7.5 seconds is only for expiration.
That's right, that's for expiration.
Where is the time for inspiration?
Very short. Keep the inspiration. I mean, you can have in these patients like inspiratory to expiratory time. It will be discussed tomorrow. I mean, but it can be like 1 to 5, right? I mean, except the very high, but I didn't want to go too much into it because Claude is going to discuss that tomorrow. I mean, we're going to accept very high peak pressures in these patients to keep the inspiratory time really, really short, right? But you're right. I mean, this is a little bit, how do you say that in English? I mean, it's a little bit too simplified. I mean, but this is the principle. Of course, you have to add the time for inspiration as well. Okay? Good. I think then I should end right here, right? Otherwise, we'll get too much out of the time. Perhaps at some other point I might save a little bit of time tomorrow and we can go into breathing effort if you want to. I'll skip this. It's not something for a minute, sorry. It is very interesting though. So, I mean, any questions about this? No. So, no, but I mean, and I think that's an important message, I think, from all the talks you heard up to now. I mean, understanding respiratory physiology really, really helps you to provide safe ventilation. And of course, it's fantastic. And you should at some point use the esophageal balloon, but only having an estimation, thinking about differences in compliance of the lung and the chest wall, thinking about resistance, about these measures of intrinsic peak really helps you to provide safe ventilation. I think that's the main message. Understand the physiology to improve your ventilation. Thank you.